So first and foremost, I would like to thank the entire committee of Youthful and RSI, our president, Dr. Himanshu sir, Dr. Gaurav, and Dr. Arora sir, everybody who is here. I think it's a great platform for all the youngsters to gain knowledge at the beginning of their career. Wish we could have had something like that. And I think Dr. Gaurav is also brainchild that has brought in such a amazing venture. So, friends, as we had this like a preemptive discussion about having your own setup or not, I think I would really agree with Dr. Gaurav when he said that it is better that instead of investing on your own, you can take access at variety of centers. And one of the reason I will say that is also highlighted in my talk is basically then you can have actually variety of technologies under your belt and you can choose the best patient for the best technology and probably take access for the technology and then do the surgery for that patient. So this is precisely what I'm going to talk to you about. So friends, we all know that refractive surgery of today is a dream realized. These are definitely the surgeries to eliminate and decrease dependency on glasses and contact lenses. They have become very big 5 to 10 minute procedures that are currently completely leadless, now also flapless with smile, with a great amount of wow effect. And the recent IIRSI survey has demonstrated that the satisfaction index of this procedure as a lifestyle modifying surgery has been the highest amongst all the elective surgeries, which is close to 97%. So refractive surgery has actually clocked almost a century, if you really see, because the first ever posterior RK, which was done in Japan by Professor Sato, was back in almost 1920, and now we are in 2020, 2021. So in this almost a century journey of refractive surgical different innovations, you have seen that there are a variety of technologies which have actually come. Some of them have stood the test of time. Some have actually have managed with the journey with time. However, now as we stand today, definitely now there are a variety of technologies that we have as armamentarium. And the thing that we have to understand, and I would like to make this mainly for also our young surgeons who would like to become a refractive surgeon, that if you want to do a refractive surgery, it is not that you become a LASIK surgeon. I think if you want to be a true refractive surgeon, you should be able to have understanding and expertise about variety of technologies which are there and customize the decision for choosing the best solution for that given patient. Just to give you a couple of examples, this was one of the patient who was referred to us for the post PRK haze, as you can see. Although the laser was done on a good machine for not very high diopter, but the patient was actually a policeman, traffic policeman. So with a very excessive exposure of sunlight, he underwent PTK with mitomycin C, and as you can see, he has actually done pretty well. But these are the kind of scenarios that we should try to avoid in our patients. Again, another patient who is an athlete was a football player, but after about 3 months of his femto LASIK, had a small injury, and you can see here he has a very small displacement. So he required a flap reposition, and now he's of course doing pretty well. So it's very crucial that we don't stick to only one procedure. We actually understand what is best for our patients, and this entire armamentarium is something that we should understand now, which includes corneal laser procedures, which involves microkeratome LASIK, femto LASIK, now also topography guided femto LASIK procedures, smile procedures, and advanced sublations. When it comes to lens procedures, we have to know the phakic lenses, phakic lens implants, and those minority of patients where nothing else is possible. A minority of these people can be still helped with refractive lens exchange as well. So when it comes to my protocols, I stick to corneal laser procedures for myopia less than 9 diopters, hyperopia less than 5 diopters, and astigmatism less than 5 diopters, if the corneal parameters are deemed suitable for such a laser vision correction. As we all know, current laser vision correction technologies can be flap-based, including the microkeratome LASIK, femto LASIK, or Contura, or they can also be flap-based, such as advanced surface ablation or smile procedure. So, going further to decide on which technology to use for this patient, if the patient already has an excellent quality of vision, has very good nighttime quality of vision, and does not have significant aberrations, definitely the different optimized platforms of today are excellent solutions that can be achieved with even LASIK, with microkeratome as well, femtosecond LASIK, advanced surface ablation, as well as with SMILE. But if you see the patient does have a lot of abrasions, especially coming from the cornea, there is a topographic asymmetry or astigmatism that you see, then a topographic guided treatment is truly a great solution for these patients to have. And I think different guided treatments overall have died down as far as the choice of procedures have concerned, and they have been taken over largely by the topographic guided treatments now. For patients who are not deemed suitable for corneal laser procedures, especially for people who have more than 9 diopters of myopia, more than 5 diopters of hyperopia, with, of course, with possibility of having good anterior depth, or the patients who have probably lower metropias, but the corneas are not suitable for lasers. Uh, and have enough anterior chamber depth. Phakic lens implants are a beautiful, beautiful solution, one of my most favorite procedures to perform. And if the anterior chamber depth is insufficient, then of course the refractive lens exchange becomes one of the scenarios. For myself, what I do is smile has become my procedure of choice and first choice currently with all its advantages. So a common or typical patient when he comes with this kind of myopic astigmatism, which is, let us say, moderate with very good corneal parameters that we are looking at, my first choice will be smile. Why smile currently? Because we have seen that the smile actually is a great marriage, and the advantages of both advanced surface ablation in the form of being flapless with slightly better stability, and the advantages of the lamellar procedures in terms of the fast recovery, completely penless course with less amount of regression and no possibility of haze has made smile as a great solution for majority of our patients. Especially today when you have a lot of people who are computer users, they already have some pre-existing dry eye. So Smile obviously becomes a great solution here because in Smile, as you know, you are actually taking out the lenticule from much below the subepithelial nerve plexus, thus preserving the corneal nerves much better than with LASIK, in which you will be actually creating a flap. You will be creating a flap and then
Dr. Rupal has to probably mute herself, ma'am.
Yes. So basically, as we see, for because of these reasons, there is also less induction of corneal neuropathy and much better preservation of corneal sensations with Smile. If you look at this study, which was published by Dan Einstein, in which he has actually compared 16 studies of LASIK and about 7 publications from Smile, and he has shown that after LASIK, there is a sudden drop in corneal sensations, which goes to less than 10%, and it takes a long time for it to recover. As against in Smile, actually the corneal sensitivity reduces by only 30 or 40% initially, and also is known to recover much faster. This corneal sensitivity restoration is also reflected by improvement also of your dry eye parameters, both objective as well as subjective parameters, having seemed to recover much faster with Smile. That's why for majority of my patients currently my choice is Smile. So let us say that for patients who have 1.50 to 8 diopters of myopia, especially if they have a pre-existing mild dry eye, and of course if they are in contact sport, I would like to go with the flapless procedures. Current patients in which I avoid to do Smile are patients who have low myopia of less than 1.50 diopters. Of course, patients who have hyperopia, we cannot do Smile currently, but patients who have pure astigmatism or very significant astigmatism more than 2.50, I do not choose to do Smile procedure on them, such as this patient. So look at this, one of the patients who was a 28-year-old, a 25-year-old male patient who came with this myopic astigmatism with a very nice symmetric bow tie, but high astigmatism as you can see here. So in such key patients, I have actually seen that the results of topoguided femto LASIK are actually better than with Smile procedure. Similarly, if you see this girl who has a pure astigmatism, in this case, of course, performing a Smile, performing a topoguided treatment will be the procedure of choice, especially for patients who are hyperopic. Hyperopia is especially important when it comes to take a call, basically because as against any other LASIK, femtoLASIK, in topoguided femtoLASIK, the hyperopic ablation are going to be bang on the visual axis. So that's why the issues with angle cover and other things don't happen, and hyperopic treatments are always best treated with topoguided treatments. So, of course, there is a role of femtosecond LASIK procedures as well as mechanical microkeratome. Overall, if you ask me in general, the femtosecond lasers are definitely my preferred choice of flap making as compared to mechanical microkeratomes. Mechanical microkeratomes of today are absolutely excellent, as we have seen with the talk of Dr. Arora sir. And we do use it for many patients who don't afford femtosecond LASIK. And especially, I use it over and above femtosecond LASIK if there is a pre-existing corneal scar, because the femtosecond lasers do not penetrate the corneal scars very well. So this was just to give you an example of hyperopia. So in hyperopia, when you treat with the topography guided treatment, the treatment is going to be more on visual axis, and that is the one that gives rise to much better quality of vision. So my indications for topo guided treatments are people who have myopic astigmatisms more than 2.5, people who have hyperopia, pure astigmatisms. Of course, I avoid it on patients who already are prone to trauma because of occupations such as being in police or if they are in defense, patients who already have pre-existing significant dry eye, and of course, patients who have epithelial basement dystrophy, because that can lead to much higher chance of epithelial ingrowth after the flap creation. Now, those are other minority of patients who are not deemed correct for lamellar procedures, and those are the people in which I take advantage of undergoing having surface ablation procedure. These people are typically when I'm not very happy with topography. So when the topography is not abnormal, but it is certainly some yellow flags, or you have a mildly variant of normal topography. These are the kind of patients where I would not like to create a flap. There are a variety of studies which have actually shown in contralateral eyes that eyes with similar topographies when have undergone PRK versus LASIK, the LASIK eye has actually ended up having ectasia, and the PRK eye, even after 10 years of follow-up, actually have continued to give good outcomes. So this is another patient who has this inferior asymmetry, fortunately has low myopia. So these are the patients in which I would still go ahead with the advanced surface ablation. Again, this patient has excellent thickness, as you can see, but I'm not very comfortable in doing a lamellar cut on patients who already have these steep corneas. So in this case, the cornea is overall okay. There is no posterior elevation, but the corneal steepness is about 49 diopters. So again, these are the people in which I would like to still go ahead and perform a surface ablation procedure because it is less invasive. Of course, you're going to come up with certain people who have more than just a minor variation in topography, such as this patient who is already a suspect keratoconus patient. If such a patient comes to you, it is very crucial that you first look at the stability of, to look at overall how is the situation of the cornea. Look at least 6 months follow-up to see that it is not really worsening too much. And if it is 6 months to 1 year fairly stable, then you can perform what is called as a PRK extra procedure, in which you do an advanced surface ablation with a half fluence cross-linking, provided that you are not ablating on the cornea too much. And we have, I think, almost a series of now almost 86 patients with such topographies in which we have done PRK extra with are decently good outcomes, and none of them have full-blown ectasia. Is there a difference between the way you do advanced surface ablation if you're doing it with PRK, MMC, epi-LASIK, or LASIK? So we had published a study back in 2014. This was almost a 3-year follow-up study of patients who underwent contralateral surface ablation, different protocols, and we have seen that whatever method you are happy with, whether it is LASIK, epi-LASIK, or PRK, MMC, the outcomes are going to be fairly similar. So indication for me to perform advanced surface ablation is typically when the corneas uh, are near normal, but there are minor yellow flags there. If you have a steeper cornea, if you have a minorly thinner cornea, but I don't go beyond 6 diopters currently when it comes to advanced surface ablations, especially for people who want to go to defense and army. Of course, this becomes one of the procedures of choice. And patients who have pre-existing dry eye, this is another possibility for them as with smile procedure. Of course, you have to rule out that the patients are not keloid formers, so you have to ask about the history of their healing after any injury. And there is no stem cell deficiency, such as people who have had long history of VKC, and of course, occupations prone to UV exposure, such as the police officer, the traffic policeman that we have seen. So this is another very interesting patient we had seen the other day. You can see the patient came with six vision with -3 diopters of spherical error. And what we have seen is vision was excellent, topography was good, but you can see that there are signs of epithelial basement dystrophy. So these are the people you should avoid to cut a flap, including smile. You should not cut a laminar cut. You should always go with surface ablation because surface ablation will also treat this epithelial basement membrane dystrophy. So for those patients who are not suitable for corneal lasers, as we have discussed before, of course, the lens-based solutions are excellent. Phakic lenses such as ICL are outstanding solutions, and I think for even young surgeons, I think probably they are very easy for you to learn. You should, if you become well versed with phaco surgery, it will become very easy for you to perform the ICL procedure. So this was another case report our team had published, in which this was like a 9 or 10 years of follow-up for patient who had -9.75 diopters of spherical equivalent, had one eye LASIK and one eye star ICL. So when the patient came back after 9 years, in the eye which had LASIK, he had regressed to -2 when he was not very happy about quality of vision. As against in the other eye of ICL, he was still able to see 20/30 to 20/25. That patient was very, very happy with the ICL in long term. So of course, when would you choose this option is for all the people who have very high emetropia, such as in this patient, or patients who have relatively lower emetropia but thinner cornea. So this cornea of 480 microns, but emetropia more than -7 diopters is due for phakic lenses. Again, coming to this eye, which is in which we have seen that the patient has very thin cornea. It's like 458 micron cornea, was already suspect keratoconus. We have to look at the overall stability of his cornea over 6 months or 1 year. But if everything seems fine, then he is a great candidate again for phakic lenses such as ICL, IPCL, RIL, whichever is the procedure of choice for you. 1 second. So basically, there are a variety of lenses. We have had opportunity to use each and every of these phakic lens, including ICL, IPCL, Actrel, as well as RIL. All of them are great solutions. So whichever your patient can afford, you can go ahead and implant them. That's not a problem. So there are also minority of such people who have emetropia way beyond 20 diopters, which is the range for your EVO-ICL. So if you have a emetropia which is well beyond those 20 diopters, such as in this case, the spherical equivalent is 22 to 24 diopters, either you can go with the Indian phakic lenses because those are the ones who will be able to accommodate such a high emetropia, or you can perform what is called as a bioptics procedure in which you do the star EVO-ICL along with either LASIK or SMILE, whatever is your procedure of choice, in phased manner, in which first you create a flap, you perform the ICL on the same sitting, then you wait it out for another 2 weeks or so, refract the patient again, and perform LASIK after about 2 weeks' time. So this is the procedure that has been used a lot in the US, especially because till the time the toric ICLs were US FDA approved, for all patients who had high emetropia with astigmatism, they used to do the spherical ICL with the astigmatism correction by LASIK procedure, bioptics. So again, coming to people who are beyond 40 years of age and who don't have enough anti-chamber depth, refractive lens exchange becomes a great solution. This is an interesting case. You can see the patient had very high, so this patient had high myopic astigmatism. Patient already had suspect keratoconus, was low anterior chamber depth of 2.67 millimeters, and had also multiple lattice degenerations in both eyes. So I think this is just to make you understand that some of the patients you have to learn to reject. So it is not necessary that you operate on each and every patient that comes to you. You have to learn to reject patients. So this is one of the patients in which you would not like to intervene. Probably do barrage laser for him, follow him up for the future, and make sure that you do not intervene for this patient. So in conclusion, I would like to just tell all the young doctors that as we discussed, it is not necessary that you buy all these equipments yourself. I think it is necessary you have your own diagnostic tools with you. You have to have access to these technologies, but you have to learn all these technologies so that you are able to give the best possible solution to your own patients. So these new techniques have really made spectrum of refractive surgeries much wider, much more accurate, and customizing the decision is what I would like to really stress on. I would like to thank again IRSI and also the youthful wing of IRSI for giving me this kind opportunity to be with you today. Thank you so much.
Thank you so much for your wonderful talk, Dr. Vardhaman. Taking off where we left off before your conversations, we mentioned that on the earlier days, patients used to come with after researching on the net. But how do you convince them in case they need another choice of procedure for the refractive power?
Yeah. So I think, as we discussed in current times, this is a very relevant question because more often or not, if you are especially in your metro, these patients will come to you with certain preconceived notions that they have. So you have to spend more chair time with them for sure because they already have certain very solid concepts in their minds that they are not very easily willing to change. But you have to spend time with them. You have to make them understand why, like, as compared to what they are wanting to undergo, why this particular procedure is better for them. So this has happened with us a lot of times because, for example, if somebody has come for SMILE and has very, very high astigmatism, let us say 3.5 diopters of astigmatism, so we tell them that if you're very keen, we can still perform SMILE, but of course the accuracy of treatment will be much, much better if you undergo topoguided frontal LASIK procedure. We also tell them and show them certain times evidences from the literature showing that this is how we choose our patients. So the patients have to believe that whatever decision that you're taking for the patient is in their best interest. And this is one of the other reasons that you should be well versed, or all young doctors have to be well versed with all technologies, because otherwise the patient will feel that because there is only one technique or two techniques in the hospital, this is why you are kind of forcing him to undergo only one technology over the other. So yeah, but you have to spend more time with those patients and show them some proof of evidence.
Thank you so much. I'd like to ask Dr. Rupal ma'am, she's just joined us, for her comments on how does she go ahead and choose what technology to use, for a particular patient in a particular case. Dr. Rupal ma'am.
Hello.
Yes, ma'am, you're audible.
Yes.
Yeah. So thank you, Rohan, and I'm sorry for joining in late. What I normally do is try and see which one would work the best for them, and then try and counsel them in a way where I'm leading them to choose that particular procedure if it's going to be the one which is going to work the best for their requirement. So it's very easy to actually make a person know what is good for them if you sincerely believe in it, and then you should actually spell out the pros and cons of what would otherwise the other techniques where it would have limitations in case you feel that a particular technique is the only one that should be used in that particular patient. Now, that's not the case in most patients. Most patients can do well with even 3 or 4 different types of techniques. And it would then boil down to whether the person wants the safest procedure, whether they want to make sure that they get the perfect result, or whether they want to go in for something which is the in thing to do, or that somebody else has been very happy about it and then they want to do. So then you can just give them all the pros and cons of each and every technique, and then you should then allow them to choose, and then they choose it depending upon their budget, their knowledge, their requirement. So I actually leave the decision on the patient. I only drive them to a particular procedure if I feel that that particular procedure is the best way to go for that particular patient.
Pearl of wisdom then, customer is the king. So, Dr. Nikhil, if I may.
Yeah, Rohan.
Yeah.
I would just say this, that it is very important what you are confident of. Your body language will reflect that. If you haven't done a particular procedure well, you're not very confident, you will not imbibe that kind of confidence to tell the patient that you're going to be doing that. So you be very sure what you are saying, and you can always lead the pathway. Leaving it to the patient, after explaining everything about every multifocal, Gaurav will also admit, end of the day, they know what to do, but they're going to tell you, Doctor Saab, aap jo kahenge wo. They'll pass on the buck to you. They very easily pass on the buck to you. Your call, doc. So tomorrow they can blame you. They have decided, but they want it from your mouth. So you walk into that trap very easily. And that's exactly what they want. You walk into the trap. They say, Doctor Saab, aap hi decide kijiye. Sab sunne ke baad, so either their neighbor has made the decision for them, somebody whom they are close to has done this procedure, and I want this only. That's how it works. Or what you are confident with. And with Dr. Rupal Shah, so she decides whatever she wants. No questions asked. Nobody dares to ask her questions.
I think there's one.
You really think so?
I think there's one more way. I just tell the patient that every eye is a unique. It's not a standard item where we can give a one procedure to all or one size fits to all. So your eyes is special. It's a unique one, and we have to give the best what is possible for your eyes, not for other eyes. So if a patient wants a smile, if a patient wants femto, if a patient wants say phakic oil or anything. But what we think is better, we have to tell them this is the best suited for your eye. Now it's your choice if you want to have it or you want to go for what you have heard here. So I think most of the patient agrees on that. I say the doctor should be the deciding one. Unless you've got a similar options, then it's okay. But once you don't have a similar option, suppose a patient is good for a smile, then we have to tell and motivate him to go for a smile only. It's not that we can just leave it the patient to go for that. So we tell them your eyes are unique. It's a special one. It requires a special treatment, and that this is the special treatment for your eye. So then the patient gets convinced most of the time.
Okay. So Dr. Nikhil, as a young ophthalmologist just entered into refractive practice, how difficult do you find convincing a patient at this age?
It all depends, Rohan. If the patient is already driven towards it, if the patient comes, there are a lot of patients who are already driven to get rid of their spectacles or something, then it's pretty much easy convincing them for a particular procedure. But yes, there are yet a lot of patients who convincing would be slightly tougher at this age. As compared to someone who's way more experienced. When they give the word, then they're much more convinced. But yes, if you do put all the facts, tell the patients what are the worst things that can happen, tell them even what is that this can be, what are the different complications, how they can be handled, and keep everything clearly on the table, then definitely yes, they do get convinced at the end of the day.
Okay. So last words on this, Dr. Gaurav sir.
So I think we've heard it all, and it's all what it echoes my thoughts as well. But I think what most of us have agreed upon is that, coming upfront, clear, and having confidence in what you're doing, these are the two keys. And of course, if a patient is making a wrong choice, then it's always good to, kind of educate them on that. But excellent talk by Vardhaman. He kind of made things so easy to go through. So I think the message is loud and clear.